Good afternoon, everybody. I'm Janet Hughes. I'm a reporter with Gloucestershire Live. I've been working in and around the county for about 20 years now. So what we're doing today, we're hosting a Facebook Live. We're joining forces with the Gloucestershire NHS because they want to talk about what they want to do in the future. They've got a vision that they want to share with you, and they actually want you to have a conversation with you and for you to tell them what you think about this vision. And it's about specialist services. And it's about the specialist services at Gloucestershire Royal Hospital, at Cheltenham General Hospital, and in the community. Now, they've already had one exercise where they've talked to you about what they wanted to do in various areas, and that's been done. And now, that was 18 months ago, and now they want to talk to you about the forthcoming specialist areas to be looked at. And I'll just run through them now. I'll just look sideways so that I get it right. It's benign gynecology, diabetes and endocrinology, frailty and care of the elderly, non-interventional cardiology, respiratory and stroke. Now, we all know it's been a tough old couple of years for the NHS, and they're the areas they want to focus on next. So we've got Mark Pietroni, who's the interim CEO of the Hospitals Trust, Gloucestershire Hospitals Trust, and we've got Dr. Charlie Sharp, who's the consultant for respiratory at the hospitals. And we're going to have a series of 6 Facebook Lives, and we'll discuss different areas in each one of them. And like Charlie's with us today to discuss respiratory. So we're going to start today with Mark Pietroni, and I'm going to ask him really, what is Fit for the Future 2? Because that's what we're here to talk about, Mark.
Thank you, Janet. Thank you for that introduction. So, as you say, this is what we call Fit for the Future 2. People who are watching or listening may remember really over the last several years, we've been talking about reorganising our services, which culminated in what we called a Fit for the Future programme. That's been completed. We engaged with the public, we consulted with the public, and now that's being implemented. And if you come to either of our sites in Cheltenham or Gloucester, you can see lots of building work. So now we're talking about Fit for the Future 2, which is the next round of our thoughts about how we organise services in Gloucestershire to provide the best quality of care that we can to the whole population. It's not about revisiting the decisions that were taken in Fit for the Future 1, nor is it about Cheltenham A&E. I'll just say that in case anybody wonders. And it's slightly different from Fit for the Future 1 in that was quite a lot about which services on which site, etc. But Fit for the Future 2 is a start of a much broader conversation about how we provide the best possible services including the community, primary care, the community hospitals, and the acute hospitals that we have in Cheltenham and Gloucester. And some of that will involve changes to the way we're working, but this is not about which side a service is on. This is about how we provide the best service that we can, and in particular, how we can provide those services in a way that will reduce waiting times, that will reduce the chance of cancellation, particularly for elective operations, that will reduce health inequalities, and that will mean that we're able to do things like catch up on some of the backlogs that we have after COVID. It's also about how we make the best use of both of our sites. We're very fortunate in Gloucestershire to have 2 hospital sites. And again, people who are listening or viewing may remember that during the depths of COVID, we kept Cheltenham as a relatively COVID-free site in order to carry on doing a lot of elective operation. And that builds on our Centres of Excellence model. So we have this model that we call Centres of Excellence. And the idea is that we will have a Centre of Excellence on both sites. In Cheltenham, it's primarily around planned and elective care. And in Gloucester, it's primarily around emergency care. But that doesn't mean that there's no planned care in Gloucester, and that doesn't mean that there's no emergency care in Cheltenham. But there's an increasing differentiation in that direction. So that's what this is about. At this stage, we're not presenting decisions or proposals. We're talking about our ideas. What we'd like members of the public to do is to listen to our ideas and then feedback and give us comments. And there are lots of ways in which the public can feedback. This is one of them. There's a bus that's travelling around the county, and there's a website that you can get linked to, which is called getinvolved.glos.nhs.uk. There you go. It's appeared at the bottom of the screen as if by magic. We want to explain our ideas and why we think these are good ideas. But at this stage, we'd welcome comments and feedback. And then we will go back and talk about that, look at comments from lots of other people. And then in due course, we'll come out with firm proposals, which we will consult on. So that's really what we're about today, Janet. I'm happy to stop there, but if there's more you'd like me to explain, please ask. Otherwise, Charlie can, of course, talk in more detail about respiratory, which is the service that we want to talk about today.
Okay, thank you. Yes, I think you've covered everything there, and in terms of you definitely want the public involved in this conversation. And I'd like to talk to Charlie, really. Dr. Charlie Sharp, can you tell us a bit about your job at the hospital and what it covers?
So I'm a respiratory medicine physician, which involves looking after patients with any problems with the lungs, which might affect their breathing, might result in a cough, and can encompass the whole range of ages from adolescence for me, because I'm an adult physician, all the way through to the extremes of age. And it's a very diverse range of diseases that we look after. And we look after people both in outpatient clinics and also where they're admitted due to acute illness or acute worsening of their existing chronic diseases. The important thing to say about what we're doing and what we're discussing today is that we're not proposing any changes to outpatient respiratory services. They will continue as they currently have, with services provided across both sites. We're talking about when we're looking after patients who have been admitted acutely unwell to the hospital.
Mm-hmm. So what is, like you say, it's not for outpatients. They'll continue to be provided at Cheltenham General and the Gloucestershire Royal. But what is your vision? Because clearly, I'm guessing you're one of the departments that was really badly impacted by COVID, and I'm sure that had some impact on what you're thinking for the future, really. And I'm just thinking, what is your vision?
So we were very much at the heart of a lot of what happened over the last two and a half years. We looked after a lot of very unwell patients, but because COVID's a respiratory illness, we had to look at how we could work alongside the trust objective. So the trust decided that the way to best serve the county was to try and ensure that the Cheltenham site was as COVID-free as possible, which meant by definition not looking after patients with acute COVID on that site. So all respiratory medicine for inpatient services was moved across to the Gloucester site for emergency admissions. And we also, because of the care we needed to deliver for patients acutely unwell with COVID, had to set up and expand what we called a respiratory high care unit, which involved giving advanced breathing support to patients who were very unwell, who needed an awful lot of oxygen, and who might otherwise have suffered done badly or landed up in the intensive care unit. And we set that up on the 8th floor of the tower block. And we were able to do that by moving services over from Cheltenham. So before COVID, we had 2 wards over in Cheltenham, which was a total of 23 beds. And over in Gloucester, we had 33 beds. Over the course of an average year, we had well over 10,000 hospital admissions. And the majority of those were always to the Gloucester site, with 77% of admissions to Gloucester in the year before the pandemic. Now, we've learned a huge amount from what we did through the pandemic, and we're really proud of how we managed to reconfigure and deliver excellent care for our patients with COVID, particularly how we learned, adapted, evolved the respiratory high care model to really support our intensive care unit and those patients who were severely unwell with COVID. And we think that that can help us deliver excellent care in the future. And we see the opportunity here to really develop our care for patients beyond COVID and with other conditions to make it as fit to deliver care into the future as possible. And the way we see that is by continuing what we have already done and what we are currently doing. We think that we will best be able to deliver excellent respiratory care by delivering it all on one site. For those with the more complex respiratory presentations. That doesn't mean everyone who's come in with a chest infection or with pneumonia will need to be at Gloucester Royal, because patients can be treated for the less complex presentations with lung disease wherever by a general physician, a general doctor. And we will continue to provide specialist support in Cheltenham, but without that defined ward base over on that site. And that's what we're currently doing, and it's working well. And over the last year, about 92% of patients with lung problems have come to Gloucester Royal, and about 8% have gone to Cheltenham General.
Okay, I think that's pretty clear about how COVID has shaped the policy. What are the benefits, though, of having it on one site, the inpatients on one site?
So we live in a world where we're all too aware of the risks of future pandemics, and our expectation is that the coming winter is going to be pretty challenging from both COVID changes, presentations with COVID, but also we're expecting the winter to be very severe for flu, learning from what our colleagues in Australia are currently experiencing. The model that we've developed allows us to adapt how we deliver care at short notice. We've described it as flipping wards internally, and it essentially means that to look after patients effectively, we cohort them, we keep them all in one area so that they're not at risk of passing those infections on to other people. And that is as true for COVID as other very contagious respiratory diseases. There's a recommendation from both the British Thoracic Society and the Intensive Care Society that we develop what they have termed respiratory support units, which is what we have called our respiratory high care. And that requires a certain level of staffing and expertise to deliver advanced respiratory support to the sickest patients with respiratory medicine. And this model that we think is the promising one for the future will allow us to do that by having a pool of staff to draw from and not dividing our resources and expertise across two sites, but rather keeping all of the most unwell patients where we can see them, and that will make care safer and better for those patients. It is easier for us to staff beds when we have everyone in one place, and we can be more flexible and fill gaps where needed and deliver more effective training to improve the quality of our care as well. And we will also be able to continue providing just the same specialist input to the Cheltenham site. And also, as we've learned, it's perfectly possible, safe and effective to transfer those who need the care that where we determine that they need more specialist inpatient care, we can transfer them up to our ward at fairly short notice from wherever they are across both sites of the hospital.
Okay, so can I just get that right? So basically, for routine respiratory issues, people can still be in Cheltenham and be dealt with by a general practitioner, but when they get severely ill and need the specialist care that was required during COVID, the life-saving care, do you think this will save lives?
I think that it has the potential. I hesitate to promise that. It's always difficult to provide evidence for that sort of outcome, but it certainly will allow us to provide the best care we can.
Yeah. Okay, then. And there must be, how many there's going to be a few drawbacks, clearly.
So obviously for those patients on the east of the county, there will be the drawbacks of travel times, and particularly for relatives, carers to visit as well, for those who would have to travel across to the Gloucester site to visit. And there is the investment needed for us to effectively deliver a respiratory support unit, as has been recommended, as I say, by national societies. But the outcomes make that investment worthwhile. So this is something which will cost to implement, but the benefits of that will be that patients stay in hospital for less time, and that will improve patient mortality and will reduce the number of patients who land up in the intensive care unit as well, because we'll be able to deliver the care they need earlier in their admission.
And is that money there yet, or do we not know that yet?
I might defer that question to Professor Pietroni.
I'm going to be covering the inbox.
Hello.
There we go. Yes, sorry, I was struggling with the unmute, as is always the case. So I think Charlie's made some excellent points there.
Mm-hmm.
The first thing to add is that it's clear that this is not about saving money.
Mm-hmm.
In fact, this is likely to require additional investment in some services. It's about how we use our resources to provide the best possible care and outcomes. So the Trust is committed to what we call respiratory high care, and the department will prepare business plans which will go through our normal funding and approval process. So money is unlikely to be the obstacle to this, but as with all investments, they have to go through the normal process for improvement. A couple of other points I'd just like to make on top of those that Charlie have said. Just two things. One of the key parts of our Centres of Excellence vision and strategy is that we do our very best to make sure that patients get to the specialist service they need first time. And there's lots of ways in which we do that. But as Charlie has said, that if we can do that successfully, it means that people end up spending shorter periods of time in hospital. And although if you're in the east of the county and your relative or loved one is on the west of the county, or vice versa, that is understandably a concern to some people. In the past, when we've spoken to members of the public, they said what really matters to them is getting to see the right specialist as quickly as possible. And so this will help that. And secondly, as Charlie has clearly said, if you are at Cheltenham General and need to see a respiratory physician, there will be respiratory physicians there to see you. We've got a number of other medical teams in Cheltenham. My own particular specialty, called acute medicine, is also in Cheltenham, and we frequently look after people with respiratory problems. And if necessary, we ask someone like Charlie to come and give us a specialist opinion. So there's no downside to the service in Cheltenham General. It's about coordinating our resources to provide the best possible care on both sites, and to make sure that patients get to see the specialist they need as quickly as possible.
So if I'm right in saying it, what you're saying is basically all the advantages are for the patients and the outcomes for the patients. The only real disadvantage is for the visitors, basically, who may have to make that trek over from Cheltenham. And that, as far as the patients is concerned, they will get a better outcome because of the...
That's what we hope. Yeah, we recognise the difficulties, particularly for some people to travel. It's not fair to assume that everybody has a car. Lots of people will be using public transport, and that is complex. And we do work with our colleagues in the local authority in particular to try and make sure that travel between the two hospitals is as easy as possible. But there is always a trade-off here, and we want to be honest with the public about that trade-off. And the other thing, again, to say, as Charlie has said, is outpatient services will remain on both sites. So even if you receive care, in this context, respiratory care in Gloucester, if you want your outpatient follow-up to be in Cheltenham, because that's closer to where you are, that will remain possible.
Okay. And can I pick on something that Charlie said? You said about you're a bit concerned about this winter, not just with COVID, but with other respiratory disease diseases or problems. I'm guessing you're talking things like flu, which we haven't had around for a while. And in terms of timescale, what are we talking about, really, about gearing up for this winter and beyond?
Normally our flu season starts to hit towards the end of November, beginning of December, and peaks in January or so. It's virtually impossible to predict for the coming winter because we have never had a period which has been so prolonged with so little flu. And experience in Australia was that it hit early and peaked early. So it makes the flu jab for those eligible and those offered all the more essential to take that up, and also the COVID booster when that comes to people and is offered to people in the autumn, because that will be the way of trying to do what we can to relieve burden on services and avoid the need for hospital admission, is to get whatever protection we can. But we are gearing up and we are making plans already for the coming winter to do what we can to make sure that we manage the best we can.
And on a personal level, it's obviously taken a toll, COVID, on NHS staff and everything. The staff, I presume, are very supportive of this because they see it as the best way forward to look after the patients, because they've learned a lot, haven't they, over the last year?
Yeah, I think that all of our, so certainly all of the medical teams are entirely supportive, and we feel that this is the most promising approach to develop our respiratory services for inpatients for the future. And our ward staff have learned a lot, developed a lot, and are now that they're settled in their new environment up on the 8th floor, those that have moved from Cheltenham have built a real team spirit and are excited to see what the future can hold for them to develop their own ward. And they're an excellent team, and they've really made the most of a change which was required by circumstance rather than necessarily anything that they would have chosen at the time.
Yeah, so it's forced upon people, but so it's already becoming a bit like oncology is a centre of excellence for Cheltenham generally, and you're hoping to do the same for respiratory.
Exactly. We hope that by pooling that, we can make sure that everyone has the training, the skills to deliver excellent care, to deliver the best care that we possibly can.
Okay, that's fine. And I don't know if we've got any questions from the public. I don't think we got that many, but can I come back to some general questions? It's not particularly about your plans for the respiratory, but we've had a few general questions in. And obviously in the news at the moment, there's a lot about waiting times. I think I'll come back to Mr. Pietroni or Professor Pietroni about this. About A&E waiting time seems to be the one that seems to be exercising people quite a lot. I was just wondering, what is the situation at Gloucestershire about this at the moment?
Yes, well, I think it's a struggle all over the country at the moment. Waiting times, I'll go through them all, and then I'll finish with A&E. So obviously for outpatients, for investigations, diagnostics we call it, and for operations, there are huge backlogs after COVID. In most of those areas, we are doing at least as well, if not better than most of the trusts in the Southwest. Because of our Centres of Excellence model and the way we use that during the COVID pandemic, we've managed to stay ahead, in particular of cancer operations. We have no patients waiting for more than 104 weeks, and we expect to have no patients waiting for more than 76 weeks, that's 18 months, by the end of this financial year. And the numbers of patients waiting more than 52 weeks is coming down. And the similar story around our diagnostics. Outpatient recovery will take a little bit more time because we're still using some of our outpatient space in response to COVID, which still hasn't gone away in Gloucestershire. We've still got over a ward of patients with COVID at the moment, which is not true in many other parts of the country. The area that is the biggest struggle for us at the moment is urgent and emergency care, the emergency departments, A&E, and in particular, the struggle we have is about getting people into the department to be seen. And when people are in the department, they get seen and they can be looked after. But because we can't get them into the department, then your listeners, viewers will know that we can sometimes have ambulances queuing outside the department. And the reason we can't get them into the department is we can't get them out of the department, and we can't get them out of the department because a large number of our beds in the hospital have patients who, whilst still having significant care needs, no longer have a care need that requires an admission to an acute hospital. And that's still running at a level that is higher than almost anywhere else in the country, and relates to challenges that our partners, particularly in community care and social care, have in providing packages of care. So this is not to say that there isn't more that we as a trust can do, and we work together with partners to do that, to do everything that we can. And actually in the last few weeks, we've done remarkably well at reducing what we call ambulance handover delays. That's those ambulance queues outside the hospital, and also reducing that number of patients who, whilst they still have care needs, no longer require an acute hospital. There's an awful lot more work to do, and particularly for patients and staff working in the emergency departments, it still doesn't feel like we've made a huge amount of progress, but there are early signs that we're beginning to really turn the corner on this. Just to reassure your listeners and viewers, anybody who comes to the department is quickly seen. We call it triage, whether they walk in, whether they come by an ambulance, and we make a rapid assessment of what's going on, so that even when waits are long, we can make sure that the sickest patients get seen first. And that's one of the ways in which we try to make sure that we keep our patients as safe as possible.
And I understand later on, one of the things we're going to discuss on one of these Facebook Lives is frailty and care of the elderly. We'll leave that for another day and another Facebook Live, but is this part of this addressing getting people into the hospital and having the space to be able to do so?
Yes, yeah, absolutely. So frailty, an aging population, frailty is not necessarily something only in older people. Frailty is about not having the resilience, whether it's physical or psychological, etc., to cope with the challenges that you face. But of course, as you get older, we tend to get physically frailer, and then our care needs go up. And one of the things, particularly as you say, will come when we discuss our plans around frailty, is how we can do much more of that work with those people and their families, not in the hospital, or when they come to hospital, if they do need admission, that admission is kept as short as possible, 1, 2, 3 days, etc., perhaps to treat an acute infection. Because we do know that particularly older frail patients, if they stay in hospital, they decondition. That means their muscles get weaker, and it actually requires more care to get them home. So once the acute event has passed, hospital is often not the best place to look after people. So one of the things we're working with our colleagues in community care and social care to look at is how we can provide much more of that care, either in people's homes or in community hospitals, or in frailty units where there's a rapid turnaround, so people come in, they get the acute care or the investigations they need, and can go back home with the support at home that they need. That, of course, frees up beds in the hospital to be looking after other patients, to help with the flow through the emergency department and deal with the issues that we've just been talking about.
Oh, well, I'm looking forward to talking about that later on in another Facebook Live. Just one of the questions we've just been asked is, will there be appropriate integration of respiratory services with outpatient support provided in the local community? And I presume that's for Charlie, is it?
Well, I'll make an effort at addressing it. So obviously we've been talking about how we think services could be best delivered for inpatients, and as I've said before, outpatient services will remain unchanged. There is a perennial perennial challenge where talking about follow-up after an acute hospital admission for those patients on the boundaries of our services and our catchment, and be that to the north and overlap with Hereford and Worcester, to the south with North Bristol Trust, and then over towards Great Western as well. And coordinating with those services is, and always has been, and will remain an exceptional challenge. What we are not proposing any changes to is our ability to follow up patients and continue the current provision of community hospital based clinics. So we provide respiratory outpatient services in Tetbury, in Stroud, in the Forest of Dean, in North Cotswolds, in Tewkesbury. So that will not change, and follow up after a hospital admission on request can be arranged for those settings. But coordinating with another trust who won't have access to all of the data from the hospital admission, all of the rationale for the follow-up, will need to wait for a more joined up NHS, which is not in the foreseeable future between separate organisations.
That's actually that. I understand that's not something that's going to be exclusive to Gloucestershire, though. I'm presuming.
No, that's a
boundaries
problem
everywhere
across the entire country,
and particularly with Wales and Gloucestershire as well, I should imagine. Yeah.
I'll just add a couple of things on that, if I may. So, as Charlie said, there's no change to service provision on either of our hospital sites, or indeed in the community hospitals. But there is also work going on to look at how we can provide more of that care in the community. And primary care, for example, is now organised in groups of practices that are called primary care networks. And one of the things that we're piloting is actually providing respiratory outpatient or respiratory consultant support to those practices. My wife's a local GP in Gloucester, and we were talking last week about how one of our consultant respiratory physicians visited their primary care network and was working with their specialist nurses, seeing some of the more complicated patients who therefore didn't need to go to hospital. And the respiratory specialist nurse was buzzing with how much she'd learned from having the opportunity to see some patients with the consultant respiratory physician. So those are all the sorts of things that we are developing, and will be part of the conversation that we're having with the what's called an integrated care system, the way in which we bring all people in Gloucestershire who work in health and care together to deliver better services for the population. And of course, from the point of view of the public, they don't really care whether service is provided by a general practitioner or by the hospital or by community trust. What they see it as the NHS, and it's our duty and obligation to make sure that we provide a seamless service, and that we provide services in the way that best meet the needs of our patients and the public, rather than expecting them to come to us.
So the main vision really, though, is about the most seriously ill patients, isn't it? Everything else stays the same, more or less? Or
well, in fact, we hope that everything else improves. So to build on what Mark said, we're currently providing that service to about a quarter of the county. It has to be based on PCN capacity to service that, and their appetite for it as well, because it's dependent on our colleagues in primary care to enable it. We're also building pathways for earlier access to diagnostic services in the community without having to visit the hospital site, and building alternatives to hospital admission through remote models of care and assessment away from the emergency department. And all of this is on our work plan, independent of Fit for the Future, in fact, over the coming couple of years. And hopefully we'll be able to transform respiratory services in particular for both outpatient and acute care, in addition to the service changes that we see as the best solution as part of Fit for the Future too.
Has COVID left a legacy of outpatient care for respiratory?
It has left us with a massive demand. There was pent-up demand of all those patients over a period of a year or two who didn't present within primary care and therefore weren't referred, and have now been referred. So we've got 2 years worth of referrals coming all within 1 year, and therefore our waiting lists for a new appointment are significant, but we are working our way through them. The other thing that COVID has left us with is an extraordinary pool of learning of what we were able to do as part of COVID, and it's transformed our attitudes to how we can innovate, how we can improve care, and how we can actually work in a much more current and future-centered way than we probably were. So it's removed a degree of stagnation about service development and allowed us the liberty to really evolve things and move forward.
Okay. I think we've covered everything at the moment. Is there anything else you'd like to bring up, Charlie or Mark, that we've missed? Except maybe to say how people how can get involved, and that we'll be doing a series of these between 1 and 1:45 over this week and next week, finishing on June the 29th when this public engagement exercise comes to an end. Is there anything else you'd like to add?
No, just I'd like to say thank you very much, Janet, to you and Glos Live for hosting this. And just a reminder of the website at the bottom of the page. We really do want to hear from people, members of the public, patients, carers, staff, anyone really who lives in Gloucestershire and might be a user of our services. And the website will also give you details of how you can get involved in other ways, face to face. As I said, there's a bus going around various parts of the county where you can talk to people if you prefer to do it that way. There are forms that you can fill in if you want to do that, and there's an email address if you just want to send us an email with your thoughts. But the website is the best place to look to start. But thank you very much again. Thank
you. And just like I say, just to repeat that, we'll be doing this between 1 and 1:45 over the next week or two. So keep, particularly if you're involved in any of these areas, I'll read them out again: benign gynecology, diabetes, frailty, non-interventional cardiology, and stroke. They're the areas we'll be covering over the next week or two. So if you're involved in any of those services and you want to hear the vision and the ideas and suggestions that are being put forward by NHS Gloucestershire, do tune in and you'll get a chance to ask some questions. Thank you, Mark, and thank you, Charlie, for being here and explaining to everybody, and we'll speak again. Thank you.